Good morning, good afternoon, and good evening, everybody. We are very excited to welcome you to this webinar on resource mapping and tracking expenditures for primary healthcare. We have a very exciting discussion lined up with several experts who are online already. We will discuss measuring primary healthcare, how it's done, what methodologies to use, why it is important, and how do we use that information. We are going to start off with a presentation based on some of the recent publications we've had in the PHC Lancet Commission, as well as some following discussions after that. Without further ado, I'm going to introduce two of my colleagues who will present before our panel session. The first one is Dr. Nuria Brixi. She is health economist, a lecturer at the London School of Tropical Medicine and Hygiene. She has extensive research experience in implementing health policy reforms, supporting countries in developing their health strategies. She holds a PhD in health economics. Followed by Katie Shepard. She is a part of the GFF health financing team. She supports the RMET portfolio and PHC resource tracking. She's very interested in use of quality data to making informed decisions, evidence-based policies. Previously, she worked with Results for Development. She holds a master's degree in international development. So without further delay, I will hand it over to Nuria to kick off with her presentation. Thank you, Nuria.
Thank you so much, Manjiri, and hello, everyone. I'm absolutely delighted to be with you today. So I'm going to be talking to you about why it's so important to think about primary healthcare, why it's so important to measure expenditure that goes to primary healthcare, but also why it's difficult and what are the options available to us to try and progress towards better measurement of primary healthcare and primary healthcare expenditure. Firstly, I know that we all know this, but I think it never hurts to reiterate it. Primary healthcare is of fundamental importance if we want to progress towards universal health coverage, towards the SDGs more broadly. And we know this because it is through primary healthcare that we provide essential health services, that we prevent and treat chronic diseases. And we've seen it with COVID. It is those countries that have had good primary healthcare systems and services that have been better able to respond to the COVID pandemic. So primary healthcare is the fundamental pillar through which we can progress towards our health system's ambitions. Despite this importance that has been widely documented globally and at country level, we realize that primary healthcare is insufficiently funded, is inadequately funded, and is inappropriately funding. And I will talk about these 3 points in a second. But what this means in practice is that in a lot of our countries, we see that primary healthcare systems or services are inefficient, that actually people don't get good quality healthcare at the lower level of the facilities. And unfortunately, that financial protection, which is so important towards universal health coverage, is insufficient and is actually going in the wrong direction at global level. And all this means that access to healthcare remains extremely inequitable. How is primary healthcare financed? So we did some research within the Lancet Commission, which Manjiri, you've just mentioned, and we've seen quite stark figures. Firstly, that actually primary healthcare is mainly funded by out-of-pocket expenditure, i.e. people who have to find resources in their pocket every time they seek care at the point of service. And that's about $12 per person per year in low-income countries. Now, we know that this form of financing healthcare is extremely regressive, and it's also very inefficient in the sense that it can't be pooled and then used to redistribute resources across the system. The second main source of financing for primary healthcare is donor funding, $8 per person per year in low-income countries. Now, again, we know what's happening at global level with aid. We know with USAID funding being cut, but also other countries cutting their funding for international development, that this source of funding is extremely unreliable. So we have now left the resources that are being allocated by government. And you see here that in low-income countries, it's a very, very low $3 per person per year for primary healthcare. And if we compare that with countries from other income groups, you see the stark contrast between this $3 per person per year in low-income countries and $840 per person per year in high-income countries. So clearly, in our countries, in our low and middle-income countries, we're just not spending enough on primary healthcare. Now, we know that it's important to spend enough on primary healthcare, but the problem is it's very difficult actually to know what is being spent at country level on primary healthcare. And there's many reasons for this, but I think that I'll focus on 5 reasons in particular. The first is that in a lot of our countries, and I say our countries because I come from Algeria, there's a lack of clear definition as to what PHC is. And unless we define what PHC is, it's very difficult then to assess how much is actually being spent on PHC because we don't know what it is. We haven't defined it. There's also the problem of the elasticity of this concept of primary healthcare. As I say, the definition is often unclear, but it also varies from country to country. Every country will have a different method of, for example, classifying healthcare providers. Every country will make different decisions in terms of what is part of their benefit package for primary healthcare. So making comparison across countries and sometimes within a country across states is extremely difficult. There's also the difficulty of tracking resources all the way down to the facilities, because we know that a lot of the primary healthcare facilities don't have financial autonomy, and as a result, they don't receive the resources directly. So we're able to track the resources that go from Ministry of Finance to Ministry of Health, down to regional and often district level, but beyond that, it's extremely difficult unless the facilities, the primary healthcare facilities, are able to receive the resources and manage them themselves. There is the problem of donors. Now, I've said that we've been relying a lot on donors when it comes to primary healthcare, but the way that donors allocate resources often is in parallel to national level systems, to public finance management systems, which makes the visibility of these donor resources difficult, and therefore tracking the donor resources difficult. And finally, and this is more of a political economy issue, you will know that primary healthcare is often not seen as a politically interesting investment. It's often much more visible to invest in a hospital, for example, in a big city. It probably will win more votes, whereas investing in primary healthcare is something that is done across the country and is a lot less visible. And this lack of interest in spending on primary healthcare is associated also with a lack of interest in knowing exactly how much is being spent. All that being said, all is not doom and gloom. There are options to try and track resources that go to primary healthcare. There's, of course, the long-term vision of having standardized indicators that we can use to compare what is being spent across countries and over time. But there's also short-term approaches that we can take. For example, trying to define specific proxy indicators, something that would represent the spending on primary healthcare. And this is very much country-specific and policy-specific. There are tools out there that are meant to help us progress towards better measurement of primary healthcare expenditures. I'll talk about a few, the main ones. The national health accounts, which Shuke, I'm sure you will be telling us maybe more about. National health accounts are well known. They provide standardized and regular information on expenditure on a wide range of categories. The issue with national health accounts is that they are quite, because they're standardized, they're a bit clunky. They don't necessarily respond or talk to specific policy objectives. And there is a time lag of T-2, i.e. the data is 2 years old. Then you have a more qualitative approach, which is the Health Policy Progress Matrix by the WHO. That's really good in helping us diagnose the challenges in health financing. It doesn't give us quantitative information, so it doesn't help us in the measurement, but it could help us in defining those proxy indicators that are country-specific. You also have public expenditure reviews. These are excellent in-depth assessments of exactly where the resources are going, but obviously these take time, they're heavy to undertake, and they're also absolutely not regular, so that they're not a very reliable source of information on a year-by-year basis. And finally, we have the resource mapping and expenditure tracking exercises that Katie, you're going to be talking about in a second. And we really see these as being a potential link between the national health accounts that are very quantitative but quite standardized, and the progress matrix that is qualitative and very much adapted to the needs of the country. So we think that this could be a way forward. Now, the points that I really want to leave you with is, firstly, obviously, primary healthcare matters immensely if we want to achieve our objectives with our health systems in general. And measuring how much goes to primary healthcare is very important, but it only makes sense to do so if we actually care about the results. Engaging in such a heavy, or not heavy, but it's such an intensive exercise makes sense if we're going to be using the results. And using these results means that once we've undertaken, whether it's an RMET or an NHA, we use this information to engage in policy discussions, to engage in advocacy material, to make sure that we guide policy decisions based on the information that we gather. The data is very important if we want to drive these primary healthcare reforms, and this data is going to help us in the monitoring and in identifying the indicators that later on will be useful for PHC expenditure tracking. It's important when we undertake these exercises that we are cognizant of the capacity that is limited in countries and the high transaction costs. So these exercises and these tools that we use must be aligned as much as possible with each other, and certainly with government approaches. And finally, it's important that we not only track how much is being spent, but how these resources are being spent. So on that note, I will hand over back to you, Manjiri. Thank you very much.
Thank you, Nuria. Perfect, on the dot. Really appreciate you sticking to the time. Next speaker is Katie Shepherd, who is going to talk a little bit about the methodology on the RMET. Katie, I will hand it over to you now.
Thank you very much, Manjiri. Hello, everyone. Thank you for joining us today. We've got a great turnout, and thanks also to the team organizing this webinar. So Nuria has already shared a little about several options for resource tracking tools. Two of those were the national health accounts on the left here, and resource mapping and expenditure tracking, or what we commonly refer to as RMET. This figure shows a sort of Venn diagram of how those two methodologies overlap and how they're unique. Whereas health accounts tracks all sources of health expenditure in a country, from government, from partners, from private spending, and from out of pocket, the RMET exercise will focus primarily on government and partner data, but it will include both expenditures and budget. This gives RMET a sort of a nice unique value add, incorporating not only the retrospective expenditure, but also this forward-looking view of financial data for health system budgeting and planning. So what specifically can RMET be used for? We'll talk here about a few of the questions an RMET exercise can help answer and some of the main purposes of RMET results. First is kind of, cover your bases. What the 5 W's. Who is funding what, where, and when, and how much? I guess technically that's an H, not a W, but how much funding is it? And this helps promote transparency of how funding flows in the country. Second is related to resource mobilization. Based on the resources available from government and donors and the estimated cost of the investment case or health sector plan, you can then determine whether there's enough funding or how big the gap might be. And if there is a gap, RMET can, be used to advocate for greater resource mobilization. Third is whether the planned resources are allocated in alignment with national priorities. RMET can also be used to inform equity and efficiency analyses. If certain priorities are over or underfunded, RMET results can also inform redistribution of resources to make sure that the priorities are adequately covered. Fourth, for RMETs that also include that expenditure tracking piece, we can look at budget execution. Are resources being spent consistently with how they're planned? Are budgets being fully executed? And are they spent efficiently and effectively in terms of timeliness and within the health financing arrangements? Fifth, and finally on this slide, where the committed resources are being spent, how can implementation be better coordinated? So this is just kind of a subset of the questions RMET can help answer, but there are quite a few, and you can start to see some of the utility for health sector planners and policymakers. This slide shows a simplified version of the process of conducting an RMET exercise. And I say simplified because it's not always a perfectly linear process. We've reflected it as a series of squiggles here to kind of help get at that, the nature of it. So building from bottom up, each country will have its own process based on health system characteristics, budget and planning cycles. And during the first phase here, this pink phase, the purpose is preparation. You're going to plan and set parameters. The team doing the RMET will determine the specific objectives and use cases to identify what they hope to answer, what questions, what priorities is this RMET going to serve. They'll also identify key stakeholders to consult throughout the process and some of the financial processes and flows that must be captured. For instance, will this be strictly resource mapping? Will it also include expenditure data? How are the two going to be brought together? The second phase, moving up a step, is about preparing and customizing the tool to make sure that it is in alignment with the priority objectives and use cases that you've identified in the first phase. You'll also want to kind of pilot and test the tool to make sure it can do what it is intended to do. And at the end of this phase, you should have an RMET tool ready and set to go for use. Phase 3 is data collection and validation based on the pieces identified in the first two phases. So based on the stakeholders and the financial processes, et cetera, the RMET team will then undertake the data collection, collecting data from government budget, donor budget, partner budget, and expenditures as well. And while the data is coming in, it's generally good practice to kind of check it, validate it. How is it looking? Is it high quality? So that you can go back and correct or adjust if need be. And finally, the fourth phase encompasses analyzing the data that you've collected, starting to package it into coherent results. Again, back to the priority questions that have been identified. How can you start to answer those? Often there will be a preliminary, sorry, not quite yet, thanks. There's a preliminary report compiled. This is good because then you can see, check the results for validation with a set of stakeholders. And once it's finalized, then it can be disseminated. Some are made public on ministries' websites, but ideally these results will then be used to inform planning and budgeting discussions. So now we can start to put these pieces together. We heard from Nuria about the importance of PHC. It is effective, efficient, and equitable, and there are a bounty of benefits and reasons for spending more and spending better on primary health care. We also know there are difficulties in tracking spending on PHC. The definition of PHC is a particularly tricky one. It's unique to each country. And of course, as with many resource tracking efforts, it can be challenging getting the right data to capture PHC spending, depending on the systems in the country. So where does RMET come in? RMET is a tool that can be tailored to unique country systems and policy priorities. So it provides a nice practical country-specific approach to starting to answer these questions. And it adds value in the forward-looking view to better link the planned financial resources to ongoing reforms and ultimately, we hope, improve health planning. Institutionalizing resource tracking is important for sustainable health financing and particularly for primary health care. We've got a number of interrelated factors that kind of feed into and can help enhance institutionalization. At the top, first, government ownership and leadership is really key. It's important to ensure the resource mapping is not just driven by the external actors, the donors. Government ownership can also help promote the use of the results. Hand in hand with that is capacity building. It's important that the RMET teams in country develop expertise in health finance data collection, analysis, reporting, as well as the capacity to adapt RMET methods alongside national priorities and to kind of grow the exercises over time. GFF has supported a number of cross-country peer learning exchanges, which are really nice opportunities to learn from real experiences in country. And I think some of our panelists coming up may be able to speak to some of those. We also have digitization and integration, which can help increase data accuracy, completeness, and timeliness. There are options to digitize the process either in part, such as the data collection, or in full, moving towards an entirely digital platform. Interoperability with other health information systems can allow for a more comprehensive view of the financing, service delivery, and outcomes. And finally, on the bottom, harmonization of RMET with other resource tracking exercises, such as NHA health accounts, can help streamline human and financial resource needs, reduce the duplication of efforts, and improve consistency across exercises. We always want to collect the data once and use it as many times as possible and as appropriate. And on that, GFF have collaborated to develop a guide for harmonizing RMET with national health accounts. And we will again hope to hear about some of that work from some of our panelists. With that, thank you so much. And I would like to hand it back to Manjiri for the panel portion of the webinar. Thanks.
Thank you, Katie. We have over 500 people already in this session, so it'd be interesting to see where people are coming from. So if you can spend a minute on responding to the poll, that'd be great. And in the meantime, I'm going to introduce our very stellar panel. Starting with Ethiopia, we have Dr. Mulligan Argao. He's a medical doctor and a public health expert. He is an executive officer in the strategic affairs team at the Ministry of Health in Ethiopia. And prior to that, he was a deputy director general in the program section of the Ethiopian Health Insurance Service. He's interested in domestic resource mobilization and efficiency. He has supported many health financing reforms in the country. He has a master's in global health and he's a medical doctor. So welcome, Dr. Mulligan. Then we have Prastuti Soiwondo from Ethiopia, also famously called Ibu Beki. I think everybody knows her already. She needs a little introduction. She is a senior advisor at the Ministry of Health in Indonesia. She's also a solo member of the steering committee of the UHC 2030 and a lecturer at the Faculty of Public Health in University of Indonesia. She was also a senior advisor to the Minister of Health and Public Health Services in her past. She also led the Think Well Institute in Indonesia and was a chairperson of the Health Working Group. And finally, she holds a PhD and a master's in public health administration and a BA in accounting. Welcome, Ibu Beki. We look forward to your discussions. And then last but not the least, we have Tanya Zava of Tapera of Zimbabwe. He's a finance professional with extensive expertise in expenditure tracking and budgeting with the Ministry of Health and Childcare. He currently serves as an acting chief accountant in Zimbabwe. And over his career, he has played a pivotal role in financial management and budgeting and ensuring efficient planning. He continues to contribute significantly for the development and implementation of health policies in Zimbabwe. So we have lots of countries being represented here, almost all the time zones, as I can see. So thank you for responding to the poll. We're going to jump into the questions. So the way it will work is we have 3 questions. I will ask them to all 3 panelists, so they will respond one after the other. And then I'll move on to this next question. So that'll happen for about 30 minutes. And then we have about 25 to 28 minutes for Q&A. So we hope that you will hold on to your horses and ask all the questions when it's time. So I'll start with Zimbabwe, Mr. Tapera. As we know, Zimbabwe has quite a bit of experience doing all sorts of health resource tracking exercises, from NASA's to NHA's to RMETs. So we are very experienced in that. So, but given all this background, what tools do you really use to track resources routinely? And how do you ensure that these different tools talk to each other? Because as we know, each time you try to undertake an exercise, it can come up with very different numbers. So how do you harmonize these different tools? How do you make sure they talk to each other and they're giving you cohesive figures? So Mr. Tabera, I look forward to your answer.
Thank you very much, Najri, for that. And welcome to all the participants and also the people who are supporting us in this exercise. So to begin with, for your question, when we do our resource tracking, we use the PFMS system, which is also it's a digitalized system that tracks the resources they are going out to every institution. Then we also have a resource mapping tool that we also introduced. That one we started in 2017, where we collect information from our donor partners, where they are trying, where in each areas they are funding disease areas, and the level of interventions, even at the district levels, primary level. So for us, in terms of funding, we are able to track, but not all 100% tracking, but we have managed to execute some tracking mechanisms within the country. So in terms of the systems, I think the PFMA system is government-wide. It looks at all the areas that funding is coming from the central government, coming to the Ministry of Health, then from Ministry of Health up until all the institutions that we have received. Yes, thank you for that.
Thank you. Thank you. I will move on next to Indonesia. Same question, Ibu Becky. What tools do you use to track resources? I know Indonesia has been able to do NHA with T-1 timeline, so that's super exciting. But what tools do you use to track health resources, and how do you ensure there is cohesiveness and consistency in these tools?
Yeah, thank you. Thank you so much, Marjorie. So Indonesia has been able to produce the National Health Account T-1 using WHO's OECD standard guidelines. So when we produce it, we involve most of the, we produce full figures, and we've been able to include all the stakeholders from Ministry of Health, other line ministers, social insurance, as well as private insurance, self-insured corporation, NGOs, and others. In addition to the National Health Account, we also produce in selected areas, selected districts, 40 out of 520 districts, tracking based on voluntary. So we use the same framework from WHO National Health Account applied to the district health office. And then with that, we've been able to estimate the primary healthcare spending also. Back to you, Marjorie.
Thank you. Next is Ethiopia. Same question. I know Ethiopia has also done, has quite a bit of experience in tracking their resources using the national health accounts, and have started the resource mapping exercise. So could you shed some light on how do you track your health resources and how do they talk to each other? Mr. Mulligan?
Thank you, Manjiri, and hello, everyone. Welcome to the session. So in Ethiopia, for tracking resources, we use different tracking mechanisms. For the government budget, we usually use the public financial management tools like the IFMIS and the IBEX. At the federal level, we use the IFMIS, and at subnational level, we use the IBEX. So this is how we track resources which are allocated to the health sector. When it comes to donors fund, we have this resource mapping tool that we use. Previously, it used to be Excel based, but now we have tried to make it on a DHIS2 as one instance. And so when we track resources of donors, they will fill their expenditure and as well possible resources that they would commit for the coming year. So that way we will track resources. The other one is, though we don't do it every year, we conduct national health account. We have been conducting for the last, significant years. Now we are on the 9th round currently. And we do this national health account every 2 to 3 years. So these are the tools that we use to track resources in the country. Back to you. Thank you.
We'll move on to the next question, and I'll follow the same order, just so that it's easier for my colleague to put the slides up. So starting with Zimbabwe, Mr. Tapera, this session, as you know, is mostly about primary healthcare, how it's financed, the efficiency and equity associated with it, and expanding the primary healthcare package. So how do you, in your country, really track PHC resources? We talked at the first question about the health resources in general, but how do you track PHC resources, and what are some of the challenges? As Nuria mentioned, the definition of PHC is tricky. To have some watertight definition to measure expenditures is difficult. So in Zimbabwe, how have you managed to measure primary healthcare resources?
Yeah, so our health sector is divided into 4 stages. We've got the primary healthcare, secondary healthcare, tertiary, and quaternary services. So under the primary healthcare, this is where we find all our facilities, the lower level, the clinics, the district hospitals. So these are where, when resources are then channeled to these areas, we can track them according to which facility they've gone to and what resources have been used there. But in terms of the donor partners, that's where the challenge, I'm now speaking to the challenges that are most common within collection of primary healthcare. When it comes to the donor partner funding, the current way that we have been collecting our data from the partners did not specify the actual facility where the activity was being done. So you find that information that was then going to constitute how much has been used under primary healthcare would be missing. So in terms of tracking, the public finance management system that I mentioned can tell you where exactly the resources have been utilized, where they've gone. However, you find that the services that can be found in the primary can also be saved in the secondary health care and also in the tertiary care. You can also get your primary services from our central hospital, or you can get them from a provincial hospital, which then makes it a bit difficult in the separation of the activities as the resources are being used at hospital level. So I think basically that's how we've been tracking our primary care expenses. Only in the partner side, that's where we need to improve on how we then report how much has been used by each level of care. Back to you.
Thank you. Next question for Ibu Beki.
Yes.
Same question. How do you track your primary healthcare expenditures? How and why? And what are the challenges that you face in measuring primary healthcare expenditures?
As I mentioned earlier, that we use the National Health Account framework to apply to the district health account, and then we will be able to estimate the primary healthcare spending. And you can see on the right graph, that is the result. The green one is actually represent the social health insurance. This is a two major source of funds from primary health care. And then the blue one is from the public health expenditures. Basically, it's sourced from government. So this we will be able to track the resources, how, where is the money come from, and then who will manage and where the money goes. As basically they go to several programs, you know. Unfortunately, with this, we not be able to link between the resources and the output. So when we want to measure the efficiency, it's difficult. And then the reports, the chart of account that is used is to aggregate. So what we are trying to do now with the transformation, as you know that in the 2002, the Ministry of Health applied the transformation. One of the 6 pillars of the Indonesian health transformation is focusing on the strengthening primary care. So we committed to pay attention how the primary care is from the supply side is ready, you know, from the human resources, and then also the supplies as well as the resources. And we also develop chart of account specifically for resource tracking for primary health care. And then we will still in the process, and hopefully by next year we will be able to apply to all primary health care, so we can measure not only the spending but also link to the output. Thank you.
Thank you. So interesting set of issues coming out of Zimbabwe and Indonesia. Ms. Dr. Mulligan, same question to you. How do you measure and track primary healthcare resources? How and why? And what are the challenges you're facing in measuring those expenditures?
Good, thank you, Manjir. So for tracking primary health care, what is allocated to primary health care or what's expended in primary health care, we need to define the primary care by itself, as has been said during the presentations earlier. So when we see it by level, what the government has allocated for the primary health care by definition can be tracked from the IFMIS. So what has been spent on the primary health care from the government expenditure could be tracked by information from the IFMIS and the IBEX, because what has been allocated will run through that public financial management system. The other one is, as I said, the national health account that we do. This one will track not only by hierarchical level, but also by services as has been defined by WHO. And the reason why we do this tracking majorly is to inform policy making, and as well also inform allocation for the coming years, because expenditure and utilization of allocated budget will inform next year decisions, and as well that is how you will make sure that what has been allocated is as per the policy's prioritization. The policy, we say we prioritize primary health care, and then unless you track what has been spent there, and it will be difficult. Just to focus on the challenges, the biggest challenge we have is capturing information at the ground level. As I said, the government expenditure could be tracked by IFMIS, but it's not only the government budget that's being expended there at the primary level. So tracking or capturing information which has been spent at the point of care is one difficulty. And the second thing is the NHA is conducted every 3 years now, so we don't have, you know, up to date or, you know, closer information. The other challenge is like there are informations that we don't capture unless we do this NHA, for example, private health sector level expenditures are not tracked unless we do this NHA, and then we track somehow by the tools. So the absence of tracking tool is one challenge for some portion of what is spent on the primary healthcare, and then integrating all the information that come from these different sources where it exists, like the government's expenditure, probably from the resource mapping data and the like, and integrating those and creating one visibility is also another challenge. Thank you.
Thank you very much. We'll move on to the third question. Mr. Topera, so how, given Zimbabwe's experience, extensive experience actually in resource tracking, how is this being institutionalized in your system? How is it, what systems have you put in place? What capacities have you built? And what are the challenges you faced in institutionalizing this resource tracking exercise?
Thank you very much for that. In terms of institutionalization, the first step that we did was to capacitate the ministry staff. We've got a team that is composed of members from the policy and planning and also from the finance department. This team has been with the resource mapping for the past 7 years, I think. They've been trained extensively on how to collect the data, making sure that it's in alignment, no double counting is also in existence in those tools. Then secondly, we have managed to get management buy-in, because when we request for the data, it's the permanent secretary who's the one of the ministry who then signs off the letters for us to collect the data, which has been a very key milestone in terms of making sure that institutionalization then does exist. We've been working with CHAI. They've been providing us with the technical support in terms of how to collect, how to clean the data, making sure that we also understand how to analyze it. Then in terms of harmonization with other systems, we've incorporated our resource tracking into the national health accounts. We've also managed to make sure that we have that component of the data collected from the resource mapping, so that we do not waste the resources by duplicating the activity. We've harmonized that exercise. Then digitalization and integration. We're on the path of making a digital system for the resource mapping, where we move away from the Excel-based system of collecting of the data, and then making sure that a partner can then complete the information from the tool that we want to design, which will then be able to speed up the interpretation of data, the cleaning of the data. That will be reduced. So our key milestones also is the Minister of Finance. Minister of Finance also made it a budgetary requirement for us to submit our resources that are coming from donor partners, the resources that we have, so that when they then allocate funding for us, it's an informed position. So in terms of institutionalization of the resource mapping, I would say in Zimbabwe, our key milestones have been achieved. Where I would repeat, government ownership from the leadership going downwards, then capacity building within the ministry, then Minister of Finance also having a key stake in the issue, and then also the harmonization with other key areas that we're collecting data from. So I think, yeah, thank you very much.
Thank you. Ibu Becky, the next question for you.
Yes.
How has Indonesia institutionalized resource tracking? And I think you highlighted some challenges already, but if you can shed any more light on that. Thank you.
Yeah. Thank you for the question. I think I would respond in 4 dimensions as what just laid out by Kathleen. So the first one is the government ownership and leadership. We are lucky that with this minister is very committed to produce a regular yearly national health account with, I think, after we produce more than 10 years, and I think we have enough capacity buildings supported also by the World Bank and as well as WHO. And I think university is also supporting for technical support, you know. And then we also we have a challenge in the digitalization, you know, because some of the data is not yet data automatic coming to the Ministry of Health. The social health insurance, the government spending, Ministry of Health and other line minister is automatic data inflow, but unfortunately for the private health insurance data and then also for the self-insured corporation as well as out-of-pocket, we still aligned with the collaboration with the Central Bureau of Statistics. We harmonize with other resources such as global funds, yeah, and NASA, and also we also collaborate with the pharmaceutical expenditures tracking. In terms of the digitalization, I think in the primary care, we identified more than 200 applications that cover the programs as well as the resource spending. And progressively, we are still in the process that we are committed to integrate, yeah, to the government is dedicated to have a national digital platform. We call it Satu Sehat. We integrate and harmonize all the data system across the primary care services. But this is still in the process. Thank you.
Thank you. And Dr. Mulligan, turning over to you, the question is the same. How have you institutionalized resource tracking in your system, and what are the challenges you faced so far?
So basically, I focus majorly on the NHA when I respond to this question. So the NHA used to be done by donor organizations outside the MOH. MOH engages in that process, but it used to be done by partners. Now we have pulled it into the Ministry of Health and are trying, still though we use support of partners, we try to do it at, by in-house capacity. So that is a good sign of institutionalization for me. And as well, trying to keep the regularity is another sign with regard to the NHA. And the SHA framework is what we use as a tool for data collection for the household level informations or expenditures. We usually try to integrate with national level studies that would go throughout the country and try to use other tools to collect information from the private sector and as well from facilities, in addition to the government public financial management systems. The challenge we have with regard to institutionalization is, the bigger one is the human resource. We don't consider that we have enough capacity of human resource at in-house level, so we need to improve that one. And that would, ensure the sustainability and as well as the complete institutionalization of the process. The other is fragmentation we have in the health financing system. We have, multiple purchasers and as well multiple resource centers or sources for the health financing. So, that fragmentation creates a challenge to track, and that is why we are currently planning to, implement a resource tracking system whereby we will create a data exchange layer which will try to, integrate information that would come from multiple information sources. So the challenge we had so far was the absence of digital tools. So this data exchange layer that we create would help us in, having the information aligned and integrated. So the digital tool absence currently is also the other challenge we have. That's all from my side. Thank you so much.
Thank you all. And I really appreciate all of you sticking to your time. So we're right on time. Very interesting experiences from 3 different countries. We can see a very pronounced government commitment from all 3 countries. The challenges are, of course, still quite extensive. Despite the government commitment, we still have challenges of operationalizing the definition of PHC. We have the challenge of allocation of donor funding which is quite substantial in some other countries, allocating the donor funding to PHC. There's fragmentation in the system and on how PHC is financed. But I think we have reason to be optimistic. All countries are making great strides in harmonizing different methodologies, taking ownership of resource tracking for primary care. So with that, I'm going to turn it over to my colleague Nuria. We have a lot of questions that have been in the Q&A section. So I will let Nuria manage the Q&A, and she will assign the questions to experts, and you can hear the responses from them.
Let me start with 3 of the questions. There's a lot around the question of how to integrate the systems. And I know that you've spoken a bit about how you have done this, for example, Ibu Becky and Dr. Mulukan and Mr. Tapera. But I was wondering, Becky and Dr. Mulukan, and don't answer quite yet, I'm going to list the questions, whether you can talk to us about the integration of financial data with non-financial information such as HMIS. So how you manage this integration of the financial data with other type of information. That's the first question that I'm going to ask Becky and Dr. Mulukan to answer. Then, Katie, I'm going to turn to you and ask you to clarify a bit whether RMET can be used beyond national level. We know that NHA is national, but can the RMET be used at subnational level? And can it even be used at local level? So, Katie, I'm going to ask you to answer that question. And then, Ibu Becky, I'm going to turn to you to give us the example of how you've done it in Indonesia, which is a very decentralized country and is obviously facing issues with being able to understand what is happening at local level. And the third question I would like to tackle, and maybe I will start with that, is the question of whether capitation is appropriate for primary healthcare. And then again, Becky, I'm going to turn to you to hear your response in relation to capitation for primary healthcare in Indonesia, because this is a question that comes from Indonesia. I'm going to start with these 3. I will come to you and ask you again, but this is just for you to prepare. In the meantime, let me start with the question of capitation for primary healthcare. In the Lancet Commission, which I mentioned previously, we looked at the way in which primary healthcare was being financed across all of the countries. And we landed on a conclusion, which was that certainly capitation was a very useful way of financing primary healthcare. And you can make the capitation allocation formula as refined as your data will allow, because we know that capitation on its own can have downsides, for example, issues related to equity. So you need to try and ensure that your capitation formula is as refined as possible and takes equity into consideration. But what we have recommended in the Lancet Commission is that capitation shouldn't be the only way in which you finance primary healthcare, and we rather have recommended a blended payment approach with capitation at its core. And blended payment approach means that we need to augment the capitation with, for example, PBF for specific services that need to be encouraged, and other form of financing to encourage and ensure that you strike the right balance between ensuring that there is a budget limitation, that there is fairness in your system, etc. So that's really the answer that we've come up with in the Lancet Commission, is a blended payment approach. But Becky, I was wondering whether you could reflect on this question of whether capitation is the right approach for PHC.
Yeah, thank you for the question. I think the question is whether capitation is the proper payment mechanism for primary care. My short answer, I think it's capitation is a good tools. It's a good tools to for the primary care. I would share what the Indonesian experience when we start the social health insurance in 2014. We apply a payment system for primary care with capitation as well as non-capitation. Non-capitation is for MCH as well as for drugs for non-communicable disease. But the others are included in the capitation. The question is whether capitation applied in Indonesia is underfunded or not, is sufficient or not. In my opinion, the capitation amount is underfunded, and the amount is flat for the last 10 years. We changed the way we measure the capitation, I think, in 2022 with adjusted capitation. Previously, we applied capitation across the region, across the countries, but in 2022, we adjust paying capitation with adjusted age and sex. So those who members are more aging and female receive higher capitation amount. So from the national health account, what we learn, what we analyze, we see the impact of this amount of capitation. We see that the proportion of primary expenditures allocated to the primary care is declined from years to years. So when we initiate the social health insurance, the primary care spending is about 18% of the total social health insurance spending. But after 10 years implementation, now the proportion is only 10%. So this is an alarm for from the national health account. I think we realize and recognize that we have to do something to modify the capitations. So we have some consultation with the World Bank, and I think what we think is capitation is already good, but only having a capitation is not enough. So we really have to have blended payment, like you mentioned, combined with the global budget. So we, with the World Bank, are now in the process of designing our global budget for combining capitation with the global budget as well as the PBF. Thank you.
Thank you so much. Thank you so much, Becky. Katie, I'm going to turn to you then. Can you tell us whether the RMET is usable at subnational level and particularly local level in highly decentralized countries?
Thank you for this question. This is a good one. So yes, it is possible to use it at a subnational level. It can either be included in the national level analysis if kind of a high level view is all you're looking for. There are also countries, Nigeria comes to mind as one example, where they are exploring an RMET type application at a state level. So looking specifically at funding flows and commitments and expenditures in that state. There may need to be some modifications, of course, but as long as the tool is set up for that purpose, and those are the priority questions you're seeking to answer, it is possible. It becomes certainly a little bit more complicated as you go down closer to the local level for some of the reasons we've already talked about. Many times the public financial management or PFM systems don't reach the frontline facilities, and then it takes a little bit of extra work to make sure that that data is captured and entered and analyzed. And so it's maybe not as straightforward or smooth an exercise, but it is possible. I'll leave it there. Yeah, thanks, Maria.
Thank you so much. Then moving on to the question of integrating financial data with non-financial output and outcome, for example, the HMIS. I wonder, Dr. Muluken, whether you have thoughts on this.
Briefly, Nuria, I mean, while you don't have, or in a scenario where you don't have a digital system whereby you track, expenditures digitally, it would be very difficult to use it, for immediate use. But how we use it in Ethiopia is we have something called comprehensive planning, where we try to do all the planning and then link it with the budgets. So the information that we have with the resource tracking will be used along the information of the HMIs. It's based on the HMIs performance that we populate our plan. So when we populate our plan, we try to analyze how much budget do we have and is it possible to achieve that target that we are setting. So that is how we try to use the information that we have from the HMIs with the financial information that we have. So during planning and as well at the end of the fiscal year when we finalize, we'll try to see the utilization and expenditure with the performance that we achieved on that specific year.
Thank you so much, Dr. Muluken. There's plenty of other questions that I could address, but before I do that, I would like to give the floor to two people who have raised their hands. David Zirishvili from Georgia. Apologies if I have mispronounced your name. And Luna. So I would start with you, David.
Thank you. You pronounced my last name perfectly. I'm surprised. It's usually difficult. My question is to the presenters who highlighted one of the challenges, definition of primary healthcare. I wonder if they had a chance to consider using two dimensions like healthcare functions and healthcare providers to help countries to come up with country-specific definitions of primary healthcare. The reason I'm asking is that we try to do this in European region and there is some encouraging results. Over.
Thank you so much, David. I think maybe this question is directed to me. Is that right? Yeah. So yes. Again, when we thought about what primary healthcare was within the Lancet Commission, we really struggled with that question of, is it services? Is it platforms? How should we go about the defining primary healthcare at a global level? And we haven't succeeded in coming up with a definite answer. And we have had the cop-outs approach of saying, well, for the Commission, we're going to be talking about services, but really what is appropriate at country level will depend on a whole host of technical and political economy considerations that are very country specific. I'm not sure that I'm giving you a very good answer, other than to say it's very complicated. And at the Lancet Commission, we haven't been able to come up with a better answer than that. Apologies if it's not quite what you were hoping for. Luna, you had your hand up as well. Luna Al-Bisri.
Yeah. Hello, everybody. I'm Luna from Lebanon. I would like to ask a very important question that really is hitting in the country where I live. It is the problem of governance within the public, if you want, institutions. So despite all the effort that the government is doing, we still do have this problem of let's say, governing everything related to financing and spending. And primary healthcare centers is one of these, let's say, infrastructures that the government is really making a priority for the public health services. But the major problem is how really in a country like Lebanon or any country where we suffer from the absence of good governance in some areas, how can we track this financing and how can we track where the money is going? And I have said that in my comments that since I am also, despite being an academician, I am a public health person, I am a community pharmacy, and I know that we can use community pharmacists because pharmacists can be used in a way if we want to be, let's say, a center for services for people, for the community and population. They can be remunerated by the government, but we can track, if you want, the financing and the spending in this community pharmacy. So if someone can help me in this, in answering this question, thank you very much.
Thank you so much, Luna, and great to have you with us. A really important question, and I wonder, Mr. Tapera, of course, the question of governance is different in Lebanon and in Zimbabwe, but you've also gone through a complicated stage with the governance arrangements that were not very strong. I wonder whether you have any reflection on this important point that Luna has just made.
Yeah, thank you very much for that contribution from Luna in terms of governance. What we can say is that over the years, the government has tried to make sure that the resource mapping and tracking and also the allocation of resources has been going towards what we find in our THSI tool, where we look at the disease burden. We also look at the environment that people are, because currently we're under the COVID, a lot of activities were shaked up then. So in terms of governance, I think there are major strides that have been coming from the government in terms of equipping and also making sure that we make decisions that are. If you look at our budget, the way we distribute our budget, the Ministry of Finance has made it a core requirement that we have a budget committee within our institutions. These are then able to then decide how to allocate the resources, making sure that all areas that are of relevance within the ministry are catered for. Then this then eliminates the issues around the poor allocation of resources, where everyone is then informed from the primary, from the tertiary, from the secondary healthcare levels, are all informed on how the resources are going to be distributed. This has helped us really in terms of transparency, fair equitability of the resources being allocated. So I think, thank you very much.
Thank you very much, Mr. Tapera. And Luna, I think this is a big discussion, and maybe we can continue this conversation offline. But hopefully, Mr. Tapera's answer has contributed some to helping. I'm going to take one last hand up, and then I'll come back to questions online. Rajesh Mehta.
Yeah, thank you so much for the opportunity. I was impressed by Indonesia's reporting in their very decentralized system. I am a former regional advisor for child adolescent health in Zero, so I know a little bit context of the country. My question to colleague from Indonesia is, at the local government level, do they have capacity to analyze the data which they get from tracking? And do they exercise power to actually improve the budgeting or financing if they find that resources have been decreasing? Because, it's largely municipalities and provincial governments who have to provide for the financing of the primary health care.
Thank you very much, Rajesh. Ibu, Becky?
Yeah, thank you for the questions. I think the question is whether the local government has the capacity to produce as well as to analyze. That is very important, since the rotation of the people of the human resources is very high there. In the local level. So what we did is now we do the TOT to the local level, to the province, and then the province goes to the district level, and district goes to the primary healthcare. So this is what we did every year, and thanks to COVID that we do it not thanks in a way, but with COVID, we will be able to do more efficiently, provide socialization through online. And then they have to produce and report it to the Ministry of Health, and Ministry of Health are the one who collect all the information. So as I mentioned, out of 540 districts, we only have 40 districts that consistently report, and the quality of data is very good. And I think the Ministry of Health giving appreciation to this local government. But how about the others? So what we need to do is we have to standardize, the reporting systems. So first, like I mentioned, we develop a chart of account at the primary care. So, and then we also ensure that there is a human resources for data entry, and with that, with the digitalization, and then we also develop a dashboard for that. So analysis would be able at the primary care with the district, province, and also with the central level. Previously, we do not have that kind of information. So our project, hopefully, we are still developing the design, and we will implement starting this year, and hopefully by next year, the data collection will be much, and participation of districts will be adding. So I think that is my response. Thank you.
Thank you so much. I'm going to come back to a couple of questions that were written, and then if we have time, I'll come back to the raised hands. Katie, all very well and good, but has RMET actually influenced resource mobilization in a country or improved expenditure tracking? Have you seen any improvements as a result of undertaking RMET? And another question to you, Katie, is how can you incentivize donors to contribute, donors and implementers to contribute their data, which often seems to be the issue with RMET?
Thank you. Hello. These are exceptional questions. I would also invite our country panelists who have done a lot of resource tracking work themselves to weigh in on this. We have seen RMET being used for redistribution of resources across health sector priorities. For instance, if there are multiple pillars in a plan and the RMET identifies that one pillar is really overfunded and the other has a gap based on, the costing and the gap analysis, those resources may be able to be redistributed to help ensure that there's adequate coverage. And then the second question, well, it's tricky. I think this is a common experience, certainly. I think the more, well, I'll offer my 2 cents and then would welcome others as well to weigh in. I think the more the government in a country, the ministry, can own the exercise and have it presented in that way, the stronger the case is to the donors. We've seen a lot of the one plan, one budget, one report agenda, where donors are coming together and supporting the government to make sure everything is harmonized under one plan and less off-budget funding and less parallel funding and implementation.
If I may jump in, Katie, I'll just give the example of Sierra Leone, where a couple of donors didn't want to give their data. And what we did is we shared with all the donors who had shared and who hadn't shared. And they felt a bit ashamed, I guess, I don't know, but they didn't like to be the only red ones on the list. And so they gave us the data. I'm sure there's all sorts of other ways. I'm very conscious of time. I'm afraid we only have time for one more raised hand. So I'm going to call on Tural Gulu.
Thank you for insightful presentation. It was really useful. I will use the materials with my partners. I'm working in Uzbekistan as a health financing advisor. My question is to Nuria. Mostly. So in your presentation, you rightly mentioned that prioritizing and investing in primary health care is not that attractive politically, and it's not visible. It's small. Most governments are focusing their energy and resources into big hospitals. Even in developed countries like South Korea, hospitals are stronger, much stronger than primary health care, and they don't let primary health care to develop. My question is that how we can change it, how we can make it a priority for the government in terms of spending and in terms of health system, how we can push governments to make their system more people-centered, more PHC-oriented than the hospital-oriented, because in many countries that we have been, governments always prioritize, and decision makers are mostly, Minister of Health are mostly coming from the hospital background, especially surgeons, etc. So how we can advocate for more PHC investment? Thank you.
Thank you so much, Tural, for this excellent question. We tackled it in our Chapter 6 of the Lancet Commission, which looked at the political economy of financing primary healthcare, and in particular tried to understand why some countries invested in primary healthcare. And often it is because primary healthcare was a window of opportunity opened. There were technicians in the background that were preparing all the work. And then for a political reason, there was the realization that it could win votes or it could advance a particular agenda. And so the meeting of the technical and the political and a specific issue in the country allowed for the sort of primary healthcare to be prioritized. But there's a lot more that could be said about this. I will ask to include the Lancet Commission report. Please read Chapter 6 because it is precisely on this question. I'm very aware of time, however, and I'm afraid that I have to close this Q&A session. We're extremely grateful for all the questions, and we hope to come back to you with documentation and things for you to read. Manjiri, over to you for the last part of the webinar.
Thank you, Nuria. Shuka is a senior health financing and expenditure analyst at WHO, and she leads the WHO Health Accounts team. So I think most of you must have seen her or met with her in your past experience for any resource tracking exercises. For over 20 years, she's spent her time at WHO developing the conceptual framework and measurements of catastrophic health expenditures and poverty impact of out-of-pocket expenditures. Her technical experience and extensive experience is in supporting countries and have shaped her to become a passionate advocate for evidence-based policy decisions. She's dedicated to advancing the health accounts as a global public good. So I welcome Shuka, and I think she will spend the next 5 minutes in bringing together the concept and summarizing some of the comments and questions and discussions we've had. So over to you, Shuka.
Thank you very much. And good morning, good evening, everyone. It's a great pleasure to learn all the experiences and to learn the challenges in different countries and your experiences, and you share your success story. So I think it's a very rich discussion, and maybe in the 5 minutes, it's just very quickly, let me first start with, the RMET and the NHA and the other tools. I think each tool has their very specific objectives and purpose, what they serve. For the RMET, as we all learned from this session and also from your work, you start with the national strategies or the national plan. You have this plan, and you have a costing, you know how much money needed, and then you map with the budget from the government and also from the donor to map with your national priority. So in that sense, the RMET is really directly serving with the country level policy dialogue and how the money is spent, whether it's effective or not, meeting the national priorities. On the other hand, the health account is also a mapping, but this mapping is rather mapped with different classifications of the health spending. It's been mapping with financing the source, the channels, and mapping with the provision, the type of the services, the providers, and also you map with the beneficiaries. You map with the disease, you map with different, age, sex, the spending. So that gave you very different perspective. For NHA, you will never answer the questions whether the money is sufficient or not. That's not the question through the NHA number you can answer. It only tells you how much you spend. Well, from RMET, you can answer that question because you have the costing, you have clear targets, so you know what is the funding gap. And for the NHA, they also include the private spending. As I said, it's really serving the whole health financing strategies and policy development, and also inform the service delivery. So that's the two major kind of tracking the resource. And in that sense, that's why for NHA, you have a so-called global database to allow the cross-country comparison, where RMET is not a global database, because every country, you have a different budget structures and you have a different national priorities. So that's very different perspective. So that's one. The second is on the PHC spending. So in terms of the PHC spending, there are two issues from today's discussion. One is to get the national level of PHC spending. How much government spend on PHC? How much donors spend on PHC? Through the RMET, you want to get that. And from the NHA, you also can get that answers, how much is spent. So in a way, to tracking the PHC, I think at the beginning we say, the concept is not very clear. The concept is not clear only at the global level. When you go to the country, you say PHC or they say PHC, they know exactly what they refer to. It's just we don't know. So in that sense, the tracking of the PHC, you can keep the global measure, like WHO, we keep the global measure, is based on the services. But at the country level, we very much encourage the country to do the service and the provider. You cross the two to see this package of services, how much is provided in the primary, how much is provided in the secondary or the tertiary level. And that gave you a lot of perspective. Then you ask questions, why primary care services, the basic package service, can provide it at the secondary, to provide it as a secondary or tertiary facilities? Should it be? What is the reason? Is that because it's not available at the primary level? Or is it the capacity is not there? Or is the quality or the perceived quality is not there? So it's not that straightforward to say, okay, you all push down. We need to understand. Well, that's one thing. Then come to the third question, and today we have a quite discussion on that. Many questions relate to that. It's the local level to understand, to answering that question, why some services is provided at the tertiary, it should be the primary level. So we need to also to see at the local level, the primary, so-called the primary care facilities, how the money is channeled, whether they arrive timely, what are the rules they had to fulfill to spend the money, whether they reach the intended purpose. So that is a very, very important. And that with national level tracking, you will not be able to answer that question. And then that is why it's a very important to also understand at the local level what it is. And then so from there, we can also link with the output indicators. There's also many participants asking why, we link the output level indicator. We need to link the output level indicator, and why we spend this money is not get the result we expected. So only through the local level, at the facility level, we have the understanding of the operation, we can answer those questions. So I think in general, it's a very nice discussion. I mean, we don't need to fix on this tool or that tool. It's really depending on our purpose. We need different kind of tools because it's playing different purpose to support the policymaking process. Thank you very much. Back to Manjeri.
Thank you all. Really, really great and rich discussion. And very good engagement from the participants as well. It's very excellent questions. So thank you.
Thank you all. Bye.
Bye.